Good morning. Thank you for joining us for today's webinar, PDPM, Performance in a Post-Pandemic World, Understanding Benchmarks While Identifying Compliance Liabilities. I'm Wendy Johnson with the Pennsylvania Healthcare Association. Before we begin, I have a few housekeeping items to cover. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and to gain a better understanding of practical application tools to equip you so that you may continue to provide the highest level of quality care possible. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for one continuing education credit for PHCA members. Credits will be uploaded to NAB within the next 2 weeks for those of you who have provided us with your unique NAB number, and I will be sending attendance certificates. A survey will be launched at the close of the webinar. Your feedback is very important to us and our speaker, so please take a moment to complete the survey. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit questions using your questions pane on the right hand of your screen, and our presenter will address them at the end of the presentation. Today's webinar is being presented by Michael Sciacca, COO with Zimmet Healthcare Services Group. I'll now turn the webinar over to Michael.
All right. Well, welcome to those of you who have joined. Again, my name is Mike Sciacca from Zimmet Healthcare Services Group. Happy to join you today and walk you through our presentation here. You know, as you can see, I put the title together a few months ago. You know, a few months ago, I thought we were on the backside of this. So, you know, when I start talking about kind of a post-pandemic world, you know, it was really in the vein that that we were on the backside of things. But you know, obviously with the current news, with the spike in cases and some more activity in the nursing homes that we're hearing from our clients, and you know, from the greater news at large, it doesn't seem like it wants to go away. And it doesn't seem like we're over this at all. So, you know, what we're going to talk about today is really the fallout specific to PDPM, both, you know, pandemic related and, you know, essentially from the standpoint that, you know, we were getting going, you know, we were 6 months into a brand new reimbursement system that was so different than the previous RUG system that, you know, we were still evaluating what was working and what was not working when the pandemic started. And what we hope to do today is to give data, and a lot of that data is coming from our partner company from Zimmet Healthcare. It's called Core Analytics. It's a software program where we take the Medicare claims from our clients and then generate benchmarks and generate, you know, logic checks on what is, you know, what's happening out in the industry. The database is pretty robust, so it's close to 2,500 nursing homes that submit their claims on a month-to-month basis. So we've been doing that, you know, almost for the 2 years that PDPM has been in play. So we have quite a bit of data to share, and I think that the one consistent finding when we're speaking with our clients is that it's very difficult to gauge PDPM performance when you're used to a very static system, you know, such as our previous one. There's so many variables in PDPM that impact the PPD. And, you know, some of it is shaded by COVID. You know, obviously some of the reimbursement drivers are different or are impacted, you know, with that diagnosis and with some of the, you know, attention that's spent on taking care of those folks. But we're going to talk a little bit about, how length of stay, how wage index comes into play, or how to best compare apples to apples. And that's what we're hoping to give you here today, is an apples to apples comparison, so that you can look at your performance and say, hey, I'm doing really well. Hey, I'm doing really poorly. What are the things that I can work on in my building or take back to my staff, so that I'm making sure that I'm not missing these opportunities. And then conversely, almost equally, the compliance liabilities, the liabilities for coding certain items without the appropriate supporting documentation. So we're gonna touch on both sides of the coin here, because you do see a pretty big variation, and we'll show you with some of the data, a pretty big variation with the performance thus far, and even the performance from the beginning of this year. So as I said, the data comes from the majority of the data comes from our proprietary system. It's current data as of July billing, July of this year billing. So, there's not that lag that you see with some of the public data that CMS puts out. It's actionable, that kind of trails the cycle of the COVID pandemic and some of the things that are impacting it. So, with that, we'll get started on the program. Again, we're going to let the questions, we're going to hold the questions to the end of the presentation. So, I'll allow, 10 minutes at the end of, essentially the presentation to answer any questions you may have. And again, we're putting a lot of data in here, and we're going to speak to how that data is manifested in some of the audits that Zimmet Healthcare does on a daily basis. Our core business is doing, chart reviews. Our core business is looking at medical records for, the PDPM drivers, and then making sure that they're appropriately supported. That's what we do for our clients, month over month. And I think that gives us a good perspective on, where things are shaking out, where the liabilities are, and where the opportunities are. So we hope to touch on all of that today. And if I do a good job, which I hope I do, if I do a good job, then we'll touch on both the opportunities and with actionable insight, and then some of the potential liabilities from what we're seeing in the medical records on the compliance side. Okay, so here we go. All right, this is a heat map. And what it's showing is if you neutralize everyone's wage index, okay? And the wage index essentially just accounts for differences in, the staff labor costs for a particular geographic area. So New York versus Oklahoma versus California versus, rural Kentucky, we're looking at an apples to apples comparison. So if you look at the heat map, you can see that New York and New Jersey, Arizona have done very well, comparatively speaking, when you neutralize that wage index factor. And what's interesting, and the first point that we're going to make here is that, and through our analysis of specific medical records, that under the PDPM system, the reimbursement is not very sensitive. So what we've seen is that there's not a difference in acuity. Okay, the acuity and the clinical presentation of somebody that's in Mississippi versus someone that's in New York is not very far off. But what it comes down to is that our clients in New York and New Jersey are doing a much better job collectively to identify, code, capture, and document those acuities. So the first point that we're going to make today is that it's not that Minnesota or Mississippi or Maine have a clinical profile that would result in almost $100 a day delta between the higher performer facilities, it's that it really does come down to your systems. It really does come down to your capture patterns, and it is not a function of the acuity in your building, okay? So the first point is we've looked at thousands of medical records, okay? Thousands of medical records, and we help facilities that are not doing very well. You know, we've identified and we neutralized rates, and we only work with clients that, you know, were coming into our engagements at a lower level. And universally, it is not, we're not finding that it's the clinical acuity of the residents that is dictating the rate, the resulting rate, but it's really the capture patterns, it's the knowledge base, it's the documentation that's leading to this difference and significant difference in reimbursement from a PPD standpoint, okay? And that's kind of the basis of what we're going to be talking about today. I'm going to give a couple of scenarios to kind of drive home the point here. And what I wanted to do with these examples is explain the different, well, let me take a step back. I'm a clinician by background. I'm a physical therapist, have been a physical therapist since the late 1990s. And you know, everything that we do from the Zimmet Healthcare side is typically done by clinicians. So whether it's a nurse, a therapist, a social worker, our guidance is usually by someone that is or has been in the same shoes as your team, as your MDS coordinators, as your clinical driver, your clinical leadership staff. So that's the point of view that we're coming from. So what I wanted to do as an initial example is to give various case scenarios that kind of prove the point that no matter where you're coming in and what the starting point is, if you're doing a good job capturing the reimbursement drivers, and there's not that many that really impact here. It's a complicated system, but 80% of it is 5 items. So if you capture those 5 items, regardless of your clinical acuity profile, the PPD comes out pretty much the same. So let's just take a look here. And in this, I'm using New York rates. Full disclosure, these slides, we had our annual conference last week in Connecticut. We usually do it in Atlantic City, but we did it in Connecticut this year due to some unforeseen factors. And these slides are from New York just because that's what we used in our presentation last week. So didn't have time to update it for a Pennsylvania facility. But let's just take the rates and understand that the examples that I'm going to show you are all in the same geographic region, the same wage index, same geographic region. Nothing's changing that influences the PPD other than the clinical drivers that we're capturing. So for the orthopedic example, on the PTOT side, not too much moving parts here. And an orthopedic patient will capture one of these orthopedic PTOT component scores. From the standpoint of the speech drivers, there's usually not that many. There's not that many that come into play here typically. The nursing drivers are hopefully one of those that are associated maybe with a prolonged hospitalization, a surgery. The driver that we most often see captured is that hospital-based IV fluid, and we'll get to some of the opportunity misses a little bit later on in the presentation. And then you have your NTA component. And the ones that come up obviously the most often are the diabetes. Everybody has a little bit of diabetes at the end here, or it's a very prevalent diagnosis code as we kind of see our aging population. And then maybe one additional NTA driver. Maybe that's the malnutrition is the example that we gave here, and that's just that they had surgery, they had a traumatic event, they're not eating very well. Maybe they were frail the resident was frail to begin with. You have those, those factors in play. and this resident shakes out with a PPD of about $799 a day for a 27-day length of stay. Okay, the resident was there for 27 days. The average rate for the 27 days was $799. We'll take a neurologic case, all right? A case number 2, same wage index, same geographic location. You have the PTOT component scores, acute neurologic. You'll have a few more speech drivers, right? You have a few more speech, and in this example, we have obviously that acute neurologic diagnosis code, maybe some speech-related comorbidities, swallowing disorder, an altered diet. Same thing here, that resident with an altered diet or a swallowing disorder may have had IV services in the hospital, captured, that diabetes, but maybe, nothing else, in that case was able to be captured. This resident, $797 for that 27-day length of stay. Okay, so $2 lower than our orthopedic case, but very much in the ballpark. Mixed medical, right? Same kind of setup here. You have a few speech drivers. You're capturing that COPD with shortness of breath, and this could kind of be your COVID patient as well. They may have acute respiratory failure that gets you that 3 or 4 or 5 NTA points. Notice that if you get to 3, those extra 2 NTA points don't give you any additional dollars. It's not linear where you add a clinical complexity and you add dollars. The way that the system is set up, specifically the NTA, is that there's tiers. And if you're on the front end of the tier or the back end of the tier, either 3 or 5 points on the NTA component, it doesn't change your reimbursement. Okay, so that's kind of leads to that sensitivity item that we talked about. So this resident is $802. So when we talk about benchmarking and we look at a facility's profile, the interesting thing here is that if we see a facility that's really underperforming compared to our benchmark, our peer group of providers, it's usually that they're missing one of these components somewhere in the mix here. Okay, regardless of the resident, they don't have, the facility systems are not in a place where they're capturing these drivers. So in the examples I gave you, which are pretty common, like those are residents that you would see, there's a delta of $5. There's a spread of $5 a day between, those 3 cases that have considerably different presentations. Okay, so the point here that we're driving home is when we look at benchmarking kind of going forward, that it's not the clinical piece and the acuity piece that's the issue. It's usually the systems that are set up to capture those acuities, okay? We wanted to give a little bit of information here just on recent data. The PTOT component, the speech component drivers, NTA and nursing, as we kind of go along here, we're going to see, the case mix creep that happens when any new system comes into play. So, from the standpoint of, all the talk a few months ago about the recalibration and CMS identifying that there was considerable inflation of PDPM reimbursement past the levels they were expecting. Our point is to our clients is that there's going to be a reshuffling the deck eventually. We got a reprieve, obviously because of COVID. We got a reprieve on that recalibration this year. But that doesn't mean that when CMS collects the data from the first 2 years of PDPM, that next year we don't see, a drastic, cut and or a cut to make up for lost time, if you will. So that's one of the big concerns that we have, that case mix is creeping here from the PDPM standpoint. The missed opportunities, we're trying to alert you to those missed opportunities so that you can put systems in place that when there is a recalibration down the road, you were at least paid what you should have been paid at the time that you're rendering services. Okay, so for the PTOT component, you see the case mix creep here in the last few months. Not significant, $4 a day is fine, but all indicators are going up. The speech component, we've seen this really level off to a certain extent. The first year in on PDPM, the average speech rate was closer to like $38 a day. So over the course of 2020, we went from like $38 a day to $44 a day on the speech component, and that kind of peaked in April, and now it's really trying to, starting to level off, right at that, $45 a day. If for lack of a better way to put it, we've caught up pretty well on the speech side. I don't expect too much more here. The MTAs, we're obviously doing much better, and this is probably the most significant of the inclines here, because when we get into the nursing component, and we'll get to that next, there's been a decline in the nursing component because of less isolation use, the less isolation from last year and the kind of the peak of COVID at, the last year's holiday season, November, December, obviously January. So the peak was there. But we're seeing better capture despite the decrease in the isolation and the loss of the one NTA point that's associated with isolation. So even though we're capturing less of that one driver, the industry as a whole, or our client base, let me clarify here. Our client base of 2,500 facilities is doing a better job on the NTA component, to the tune of $6, $7 a day, which is significant. And then we have the nursing. And as I said, the nursing component is specifically due to a loss or reduction in COVID cases, and it's due to a reduction in the isolation that we've seen as a treatment for, or as a procedure for those COVID cases. This is an interesting slide here, and again, we're throwing a little bit of numbers here, a little bit of data, but I think that this is the real basis for a lot of what we're seeing and a lot of what we're doing. There's obviously an inverse relationship between special care high capture and isolation. So as we saw isolation increase, we saw special care high for the nursing component decrease. The important part here is that top red line, which is the additive or aggregate of those two categories. That's the number that I think is going to be the one we follow for a mature system. I think that this shows that there is still opportunity or a significant amount of opportunity for the for this component. We'll see this in a little bit, but our top 10% of providers do a much better job on this combined special care high and extensive service capture than our database average. And if you're going back to your facility and have one question to ask, and this is irregardless of actual PPD, if there's one question that your MDS team and your facility reimbursement team should know about, is your special care high plus isolation capture rate. Okay. And our average right now, as of July, was about 49%. The target and where we see this going is somewhere between like 55 and 60%. I think that that's the new ultra high, KPI, if you will. And when under the old system, if you asked about kind of that, about how the facility is doing in a very small snapshot, you kind of looked at your ultra high capture rate. If it was 10%, you knew there was a problem. Same thing for special care high. If you're at 20%, something's the matter. A lot of the extensive service has to do with your COVID activity in the building. If you have 0% COVID activity in the building, then you would expect to see 55, 60% special care high capture. And that's the only question you really have to ask. So, take home number one here, and, I like to give actionable recommendations, but take home number one is if your MDS coordinator can't tell you how you're doing on your special care high capture percentage, you're probably missing out. Okay, you're probably missing out. It's the one KPI that you should know and you should have month over month as a function of performance under PDPM. So we saw this significant increase on the special care high with the advent of PDPM from October 19 to February of 2020. That came down with the increase in isolation coding, or the extensive service coding that we had. And obviously recently we've seen that COVID activity go down, and then special care high capture rates go up. I don't know how kind of the recent surge in some parts of the country is going to really impact this. I've spoken to friends down in Mississippi and Louisiana, and it's a nightmare down there. I'm assuming that we're going to see this blue line come back up. I even heard from a Texas friend yesterday, and they had 6 or 7 breakthrough cases in their nursing home, all asymptomatic, which is good, but they had some positive cases on a relatively small building, with 6, 7 cases that popped. So we'll leave that there, and we're not going to dwell on it too much more. Okay, so the next few slides here, is really just breaking down the data for each of the components. What we wanted to give you, again, this is Core Analytics January through July 2021. Part A claims only, and we're going to break down each of the components. The top 10% of performers are average in the database, and then a bottom 10% of performers. So one of the things here is the PTOT component is not a huge mover on your rate, and we'll see this pan out in dollars a little bit later on. The PTOT component just it just doesn't have a whole lot of sensitivity. Let's put it this way: the PTOT component is hard to screw up. It's hard to mess up with what you're doing. We've been saying this for almost 2 years. The certified coding and the real emphasis on this component is essentially missing the boat on where you should be focusing your time, effort, and money. This is not where you would be focusing your time, effort, and money. One thing that can be said is that the top 10% of providers are doing a little bit better in capturing days outside the medical management. So they're seeing more ortho, and they're capturing more acute neuro. And the example here is when a long-term care resident maybe picked up on the waiver, had well, I don't know if I would say waiver, but went to the hospital with a UTI, right? A UTI exacerbated their physical abilities due to a previous CVA. And when the resident comes back, the UTI is relatively resolved, and the main reasons for skilled care is to get their functioning back, the functioning back to pre-incident levels. And a lot of that had to do with that, that hemiplegia, or that, the previous neurologic condition. So, supporting documentation for that, would help get the resident from the medical management to the acute neuro clinical bucket for the PTOT. Not a huge thing here, but definitely something to consider. GG function, I thought this was interesting. We spoke about it a little bit more. The top 10% of providers, actually, the section GG coding indicated a higher level of dependence, which is counterintuitive for this section here, because out of each of these categories, the GG coding for 10 to 23 is the highest reimbursing of all these GG thresholds. But counterintuitively, the top 10% of providers coded more dependence, as indicated by that 0 to 5, which impacts the nursing component score. So let's table that for now. The speech component, it's the top 10% of providers just did a better job of capturing something. It was, essentially, the none, neither, they did a better job of capturing something. So they captured, the impaired cognition, the swallowing disorder, those speech-related comorbidities. This is a difficult one to discern, but they just had processes in place to capture something, okay? And I think that that's the important piece there. The nursing component. So I wanted to spend a little bit more time here because this is probably where, the most can be done and the biggest bang for your buck can be had. Right here is where this tells the whole story. Okay, the top 10% of providers had a combined 77% of their days in extensive service and special care high. So they had processes in place to capture those. If you look at the bottom 10%, I can guarantee you that they didn't have a significantly different resident profile than those top 10%. I'm sure they had their COVID cases. I'm sure that they had residents that have post-surgical. They just captured so many more cases in the lowest category, right? That reduced physical function category, where the bottom 10% captured 35.6% of their days. I find it very hard to believe over the course of the last 7 months that those facilities had a level of acuity that didn't spike anything, that didn't capture any, even the clinical complex, special care low, special care high drivers. We've just seen it. I think the easiest thing to say is that we've seen in our clients that is not a representation of acuity. It is a representation that maybe they didn't get the hospital documentation. Maybe they don't have a system to capture the shortness of breath. Maybe they are not providing respiratory therapy treatments, which is something that we're seeing a lot of, especially because we have so much COVID going on right now. The respiratory therapy and those breathing treatments and those breathing exercises are, something that is almost a clinical necessity at this point. So those all fall in that special care high category. And, I just have a very hard time believing that the clinical profile of that bottom 10%, yields itself to less than 20% combined of the special care high and extensive service. I just find that very hard to believe. Okay, and then again, the bottom 10%, had higher section GG scoring, which had lower section GG scoring, which indicates a higher level of dependence for their residents. So, whether that was a purposeful exercise by the facilities, and it was one of those interesting things that was like an aha for us, that this piece came up and came out when we're looking at the data. Last thing, depression. I don't, we said before PDPM that this was going to be one of the hardest things to account for, and one of the items that was so dependent on facility systems. and it panned out. We're in the middle of, a once in a lifetime pandemic where, the majority of residents at some point were isolated in their rooms, by necessity. And with everything going on in nursing homes, if you had 4% capture rate of depression for your population, I guarantee it's not, manifesting itself clinically. That 44% or 45%, if you round up, of the top 10% of providers seems like a much more reasonable, figure to be at. So that top 10% did a better job on the interviews. Had systems where they elicit, really the true feelings of the resident, because I almost find it impossible that, that I can guarantee you the staff depression rate was much higher than the 4.4 or the 19.9%, and much closer to the 44.8% level. So, we'll leave it there. And this is just to say a heat map on the same. I don't think residents were more depressed in Illinois, in Ohio, in New Jersey, or in New York. I think it was a function of our systems, and a large swath of the country had less than a 10% capture rate, and I very well doubt that that is clinically based. I'm quite sure that it's based on facility policies and procedures related to that interview process. NTAs, just to kind of go to the bottom here, from the NTA component, top 10% providers did a better job of capturing something, right? Capturing, something, and accretively, in all levels, there was marked improvement in their capture. The bottom 10%, 30% of your days, if you look at these two, right, you had 35% of your days without a nursing driver, and 30% of your days without an NTA driver. I don't know if anybody can kind of give me, a clinical profile of someone that would come in to our nursing homes in, July of 2021 that would fit that bill. So from the standpoint of, clinical presentation, it's just, it just comes down to how we're doing it in the buildings. We'll keep going here. Okay, so this may come out a little bit crazy, but and I wish that what happened here. All right. All right. Maybe I'll just explain this. Let me go back one. Okay. So a lot of what we talk about was just the average PPD and the average rates for going forward, let's just say. The average rates, the average PPD for the population. And what we want to make sure that we account for is the structural presentation of the PDPM system with the front-loaded NTA components scoring for the first 3 days of the stay, where you have a tripling of that NTA component. What you see is longer length of stay. So if you have a longer length of stay, it actually, despite capture patterns, it reduces your PPD. And conversely, a shorter length of stay will increase your per diem rate. So what we want to do after first neutralizing for wage index variances is now to account for length of stay variances, okay? So it gives a true depiction of how you're capturing the clinical drivers. The example here is for the same resident, okay? For the same resident, if you have an average length of stay of 7 days, same HIPS code, meaning you capture the exact same drivers on both of these residents, the average PPD was 845 days. If that same resident was in the facility for 65 days, the average PPD would be $759, okay? So you have both ends of the extreme. $845, you think that you're rocking it, right? You're doing a great job. You didn't miss a thing. My team is the best. You have a 65-day length of stay. Well, what the heck am I missing? You know, my rate is terrible. You have to account for it on the outlier stats. Now, if your average rate is, you know, close to the national average of about 27 days, and we use 25 days for our analysis here. And I'm sorry that the slide came up a little bit busy, but that's probably just a formatting error on my part. The average rate here was 784 days, and that's using a 25-day length of stay. Okay, so we indicated the days 1 through 3, 4 through 20, and days 21 to discharge. And this was the average PPD. Okay, so the take home here is that if you have an aberrant length of stay for your Medicare population, you really have to neutralize to make sure that you're benchmarking properly. Now, if your average length of stay is about 25 days, 27 days, 28 days, you know, anywhere from 25 to 30 days, this really doesn't come into play. Like kind of, you know, the laws of large numbers kind of average things out. But if you have a really short length of stay or really long length of stay, your numbers are going to be skewed. Okay, so when we did that and we used the Z-rate comparison for the benchmarking, you know, we found this here. Okay, there was a $150 a day delta between the top 10% of providers to the bottom 10% of providers when we used an average wage index of 1. Okay, an average wage index of 1. There was almost, you know, almost a, you know, $80 a day difference between our average and the top 10% of providers. And where was that difference? Like, that difference is right here in the nursing component and right here in the NTA component, not so much in the PTOT component. Obviously, you know, it's the, you know, what jumped out at us when we do this, like, could this be right? Was that the PTOT component was the same between the top and the bottom 10%. And the reason for the top 10% was so low was because of that section GG scoring, which inflated or increased the nursing component score, right? You get a higher level of payment for more dependents in the nursing category. And that's what we saw here. So you saw almost $100 a day difference in the nursing component score. And that's why we spend so much time on that special care high driver, because that's where all the opportunity is. You know, that's where all the opportunity is. And if you're scoring low in that area, it's not because of the acuity, it's because of your capture patterns. And if there's one thing that I can say, is I go back to my team and ask what my special care high rate is, or capture percentage rate is, and if they can't tell you, or if it's low, there's something amiss, and somebody's got to start digging to peel that on you. Okay. IPAs. I'm not going to spend a whole lot of time on this, but this was probably the most fascinating piece of our study here when we were preparing for our presentation, that the top 10% of providers did more IPAs, meaning they were more in tune with clinical changes and the reimbursement impact than our average database. So that this is a comparison of our average database that completed about half the IPAs as our top 10%. An IPA is just like a change in acuity. So maybe you missed something on the first 5-day assessment. Maybe there was a change in clinical presentation later on in the stay. But either way, the facility was attuned to this and completed twice as many of these assessments as our average database. The interesting thing here was that it was on average, it was completed day 25 of the resident stay. So something happened at that 3-week mark that changed and led to the piece where reimbursement could be impacted by doing this additional assessment. And almost more interesting is that after the IPA, the resident almost stayed an additional 21 days an additional 21 days from that date of IPA completion. So it was interesting on both sides. You know, it was a long length of stay. Something happened. It triggered the clinical team to review the case, and the resident stayed for quite a bit longer. You know, nothing really to speak of here. You know, the one thing that I will say is from the IPA perspective, the days following the IPA was 24 days, not 21, I'm sorry. And the average per diem increase was about $93. So, you know, almost $100 a day increase because of that IPA completion. And I think that we're going to see a whole lot more of these as we become more mature, as we become more proficient in the system. So, you know, I think next year when we have this conversation, we'll be talking a lot more about IPA completion than anything else, because it does really move the needle. You know, from a financial perspective, it's $100 a day. It's not like you're talking about, you know, something that was, you know, move it $40 a day or $50 a day. It's, you know, it was $100 a day in difference here. We're going to pivot a little bit here. We're going to pivot just slightly onto the compliance end. And all we want to, you know, I did want to leave 10 minutes here. All we wanted to do was to bring up the fact that the current PEPR report doesn't give any real tangible information. You know, I think that CMS will revise it, and we'll get to a point where it's actually identifying some of those key reimbursement drivers. But what we developed was a report that indicated what we felt was going to be the drivers that impacted reimbursement. Like, we all know that length of stay, we all know that, like, in the old system, ultra high capture rates was one of the big driving factors of payment and of compliance. You know, we're looking for similar items. So when you have these drivers, and we picked ones that we know impact reimbursement, and when you compare to the database, you know, the LD, Medicare publishes data from all Medicare claims that process through the system. So from the standpoint of a comparison, all we're trying to do is to look at items that are likely targets and where you're a statistical outlier to your peers. So in the example that we show here, if you're in the 99th percentile, you know, for this imaginary seasoning care center, you know, we call this our SALT report as opposed to the PEPR report, because we're a bunch of smart alecks from New Jersey. You know, when we look at this, you know, and identify items where a statistical outlier from the national percentile, Medicare used 80% on the PEPR reports. You know, that's obviously something that we would be concerned with. But if you're in the 95th, 99th percentile, all we're talking about here, now that we're pivoting to compliance, is that you did a really great job of capturing. Now, how do you make sure that the documentation is in place to appropriately cover it? We feel that the important first step is to know when you're a statistical outlier, know when there is items that that would be potential liabilities on your end, and then to address it. So just to go through the report, and from the compliance perspective, you know, you have your primary diagnosis code that you know, you really want to make sure is consistent through the interdisciplinary team. You know, what we're seeing in a lot of cases is really a lot of contradictory information between the physician, the nurse, the therapist, you know, the dietitians. Everybody's kind of coming at it from their own perspective, and to land on that primary diagnosis code, or the primary reason for skilled care, you know, the clinical team should really, you know, have a process in place to make sure that the information jives. The speech drivers, same thing. You know, the primary code impacts that acute neurologic condition and also impacts the nursing component score. You have your interview process that you want to make sure is consistent with guidelines. And then that documentation of the diagnoses, you know, to support that diagnosis is active, right? So an active diagnosis, whether we're talking about speech, whether we're talking about NTAs or even the nursing component, is that it impacts care, right? So that there's a care plan in place to address that concern, okay? Whether it's an old CDA, whether it's a new UTI, whatever it may be, there needs to be documentation to support that it's impacting the care that the resident receives. And whether that's in a care plan, whether that's in a nursing note, a physician note, therapy notes, doesn't matter. It really needs to be in there somewhere to support that driver. Okay. We talked about the nursing drivers here, the extensive service. The one thing I will say is, as we're have gone through this pandemic, the two questions we received were on the 1135 waiver and on isolation coding. And the one thing that I will say is that the RAI guidelines for isolation coding has not changed because of COVID. Okay, and they may be in contrast to guidance that you get from the State Department of Health or from the CDC. One doesn't impact the other. I don't know how CMS is going to eventually adjudicate, any of these cases. But what I will caution you is from the isolation standpoint, and if we're ramping up again, then we might as well talk about it again. The isolation coding hasn't changed from the RAI guidelines that are in place right now. An active infection, single bed, and that that you have the orders in place and the census records to support why the resident was coded for isolation. Special care high. The one thing I will say about special care high is I have a grave concern that the more I speak about this, the more facilities are going to capture that IV fluid driver from the hospital. And as the capture rates go up, great, but the support to hold on to that one piece of paper that you received from the hospital gets lost in the ether. And I'd hate to see, the good work and the appropriateness of capturing it, and then for us to lose that one piece of paper in a soft chart somewhere in the dungeon of your nursing home. So my big take home and my big recommendation, and what I tell all of our clients, is for that specific item, make sure it's uploaded into your EMR. I don't know who's can do it, whether it's medical records, admissions, MDS. I don't care, to be honest with you, but it needs to be in the EMR, because I have grave concerns that this is the one piece of paper that's going to be missing. And right there is $120 a day for each of the residents that you capture it. Okay, so if you can't support the $120 a day, there's no way you're getting it from the hospital 3 years from now, right? You're not going to go back to the hospital. Can you print up the IV medication, the IV fluid, documentation for Mrs. Jones that was here in 2019? That's not going to happen, 3 years from now. It's going to be one of those things where you're dinged and you're going to put back a significant payback. So you do one thing, just upload that one piece of paper, please. BPD, average length of stay, those drivers, obviously, we looked at the targets. Obviously, you have to look at those statistical areas and make sure that they're captured and properly supported. And then the average length of stay is, specific to the same criteria we had in the RUGS system, that the resident required daily skilled care for the duration of the Medicare case, or the Medicare stay, sorry. In that case, you have to have that clinical documentation, whether nursing or therapy, and it supports daily skilled care, regardless of what you're billing from the PDPM standpoint. A very low rate or very high rate, doesn't matter if the resident shouldn't have been there in the first place. So that emphasis on supporting documentation never went away. And I'll leave you with that. The emphasis on appropriate support for your continued stay, needs to be in the case, because it's not like we're talking about a driver for $10 a day. We're talking about the full boat. Whether they're the Medicare intermediary will knock off significant days or weeks of the episode when you're talking about, $600-700 a day in average reimbursement. So with that, I left 5 minutes instead of 10 for questions. Please reach out. Thanks for having us here. Obviously, from the standpoint of Zimmet Healthcare, we appreciate what you're doing and your difficulties. So if you have any questions, feel free to ask now or reach out. My contact information is there, michael@zhealthcare.com. And thank you for your time.
Thank you, Michael, for sharing the information with us today. We are open for questions at this time, so if you do have any questions, please submit them in the questions box on the right hand of your screen, and we'll get to them here in our couple minutes that we have left. We have another PDPM webinar coming up in early September that was just scheduled yesterday. That's going to be set for September 9th, so look for that information coming up. And then we do have our October convention that is also open for registration. Look for more information on it coming out weekly. So we'll just give it a minute or two here as we wait for questions.
Maybe I did such a good job explaining it that there's no questions left available. Is that possible, Wendy?
I think that's the case. Absolutely. Good job.
Yeah. Well, you have my contact information as well. So if anybody has a question, they're more than welcome to reach out directly and ask.
Yeah.
And if anybody wants their data run, that's an offer that we give as well. So if anybody wants us to run to see how they're doing, you can reach out to me as well. We'll need some paperwork filled out, but we'll do a complimentary for your members, as a thank you for allowing us to participate in the webinar here.
Oh, fantastic. That's a great deal. Thank you, Michael. And again, I'll provide Michael's contact information, the handout, and the recording in my follow-up email, which hopefully will go out later today. So again, stay on to complete the survey, please. Today's webinar recording will be made available on the PHCA website. And again, please be sure to check out PHCA's scheduled webinars that we're currently planning through the remainder of 2021, which is hard to believe. Again, thanks, Michael, for today's presentation. I just want to wish everybody a great remainder to your day and the rest of the week here with Friday coming up. And everybody stay well.
Yeah, definitely. Stay well. Okay.